And good morning. Welcome to our live stream from Deuk Spine Institute. I'm Dr. Deuk Majan here with my team. We're getting ready to start our first surgery on May 9th, 2023. Our patient presents to us from Michigan with 4 herniated discs in his neck. He has been suffering in pain for 15 to 20 years. The last 5 years have been horrible. He's been recommended for a fusion. He didn't want one, so he came to Deuk Spine for the Deuk laser disc repair. We're going to get started. We got a lot of work to do. We're going to fix 4 discs through 2 4-millimeter cuts, tiny little cuts. There's going to be no metal, no fusion, and no hospitalization. All right, first thing I'm going to do, our patient is intubated and asleep. It's a little bit of resistance here. Okay. How's our muscle relaxation? Let's give it just a slight...
0 twitches, I give some more.
You did?
Yeah.
All right. Let's just see what we got. I think we're going to be okay. So the first thing I'm going to do is we're going on his left side. I'm going to palpate his spine between my fingers. And shot. We're going to place our needle at C5-6. 2, 3, 4, 5, 6. Everyone agree? Let's get an AP. I want to check the lateral view and the AP view. AP is a front back. Just quick AP. Don't position. That looks good. Let's go to our lateral view. So the tip of the needle appears to be in the middle of the spine where we want it. Shot. I'm going to use the lateral view to guide the needle to the C5-6. 2, 3, 4, 5, 6. All right, shot. Looking good. I feel the disc. Let's go AP. We're going to check the front back again. We want to be in the middle. You can be about 7 millimeters to 8 millimeters off the midline. That looks good. Let's go back to a lateral. So I'm at the front of the disc. Now I'm going to pass into the disc with the needle. Shot. Shot. Let's get an AP view. Quick AP. That looks really good. Yeah. All right, lateral. So we're inside the disc with the needle. We're going in through the front. And we're going to treat the herniation in the back of the disc on both sides. Okay. First thing I'm going to do is a discogram at each disc. We all agree this is 5-6. 2, 3, 4, 5, 6. Let's count, Jordan. Show everybody C2, 3, 4, 5, 6. Show us the needle. Good. Show us the endotracheal tube in the front. There it is. It's the single straight line. And then the braided esophageal temperature probe. So that's inside the esophagus, the braided one. All right. Let's show our video on... Well, first of all, let's get our discogram. You can see the dye leaking out the front. I'm going to advance it just a little bit more. Shot. All right. And shot. All right. Shot. There it goes. I think it's just leaking out the front. So there's a tear in the front of the disc as well, which we're not fixing today, by the way. And, of course, there's a tear in the back of the disc, which you can barely see. And let's take our guide wire. Show us the tear in the back. Yeah, thank you, Jordan. That's excellent. Can you see that, Henry?
Yes, we can.
Very thin. Shot. I'm going to place my guide wire. And once I get the guide wire in, now we're going to make our incision. So this is a surgery because it requires an incision. Albeit the incision is 4 millimeters. It's very small. I'm giving some numbing medicine under the skin. No epi, right?
No epi.
All right. We're just using some lidocaine, marcaine. We're going to make our incision. It's 4 millimeters. We're going to fix 3 discs through this one incision. Now you don't want to go too deep because you could damage something deep in there, so you just want to get through the skin. And of course there are going to be veins which will bleed. If you're lucky, you can avoid the veins. Shot. But everybody's got veins in their neck, and you're going to end up having a little bit of bleeding from the veins. It's normal. You just don't want to have arterial bleeding. That would be bad. The artery would be the carotid artery, if you had it. Arterial blood looks very different than venous blood. Shot. All right, so as I'm doing this, the guide wire is going in. I want to pull it back a little. Shot. And shot. Great. I'm going to bring the guide wire back a little. Shot. Perfect. And I'm just advancing this dilator down. Okay. Shot. I can actually feel the herniation in front of the spine. We're not here to fix the herniation in front of the spine. That's not causing problems for the patient. It's only the herniation in the back of the spine. Let's get an AP view with the X-ray. Once again, we confirm our level 2, 3. Yeah, and you can see the tip of the dilator, which is in the front of the disc. Show us that. Yep. That's right in the center. Show us where the center of the disc is. That's correct. And if anything, we're maybe 1 millimeter or 2 off midline, which is not a big deal at all. You can be about 1 centimeter at most. 1 centimeter is 10 millimeters off the midline. I wouldn't go any more than 1 centimeter. And the reason is that off midline, you're going to start getting into the longus colli muscles. And the longus colli muscles are these muscles that run along the front of the spine, the front of the disc and vertebral bodies. Shot. And guide wire is going in. And the longus colli muscles, take the guide wire out. I'm going to tap this in. Well, they contain the sympathetic trunk. You don't want to damage the sympathetic trunk when you're doing surgery, whether it's open or endoscopic. It's much easier to damage it with open surgery like ACDF, which is anterior cervical discectomy and fusion. If you damage the sympathetic trunk, either the left or right, you're going to get a Horner syndrome in the patient, which is, if you look it up, HORNERS. It's a complication you don't want to have. It's not life-threatening, but it certainly will be there for the rest of the patient's life. And there's no way to get rid of it. So it's best to avoid it. Stay away from the longus colli muscles. Shot. Now we're going to have to watch the tip of the dilator carefully as I advance the tube into C5-6. We're starting with C5-6 because I'm going to try to get 4, 5, 5, 6, 6, 7 discs all done with 1 incision. To do that, I need to start with the middle disc and then move my way up and down, or down and up. Nice. So the tube is going in nicely without much resistance. I'm watching the tip of the dilator, making sure it doesn't go back any further. Show us where the spinal cord is. Follow the arrow. That's where the spinal cord is, okay? It's behind the disc. And again, I'm just nice and slowly, little taps. Can you give me a little distraction, please, on the head? Just some inline traction. So we're going to pull and try to open the disc space another millimeter just to finish off. Okay, now hold on. Come off. Take that off. Take it off. Good. Shot. I'm going to bring the dilator forward a little bit into the epidural space. Go ahead. And I want the tube to follow the dilator. Just another millimeter would be just fine. That looks good. That's as good as we're going to get it. Now that we have our tube docked at the back of the disc, can you guys see that?
Yes, we can.
We're going to remove the herniation in the back of C5-6. Can you all see this tube, Henry? How small this incision is right here?
Yes, we can.
4 millimeters. Let's get the measuring stick. Watch out for that needle. Let's get the measuring stick. All right. I know is the lighting good enough? Let's get some lights on here.
Looks good.
Let's just put them on anyway, because I want to get no shadows. There's your incision right there. It's 4 millimeters. That's only possible with the Deuk laser disc repair surgery you're watching now. It's not possible with any other type of spine surgery. If I was doing the ACDF, folks, this is what the incision would look like. From here all the way up to here, okay? That's the incision for an anterior cervical discectomy infusion if we're treating 4 discs. You can see very big incision, lots of bleeding, a lot of scar tissue, and that's why patients have a 50% complication rate with ACDF. It's high because when you're working around delicate structures and cutting them and moving them, you can damage them. All right, let's get the scope in. Let's show our audience, why do herniated discs cause neck pain? There's a reason for it, folks. It's inflammation. Let's show them how inflammation causes neck pain.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. I hope you enjoyed our video animation. It explains just how a herniated disc causes neck pain. As a matter of fact, the same applies for back pain. You can see the herniation down here. I'm actually doing what's called an annular debridement. This is the hallmark procedure of the Deuk laser disc repair, is an annular debridement. Look at the herniation, twisting and turning. Here it comes. You guys see it? Here it comes. There it is. Just popped out from, it was pushing on the spinal cord, just rolled right out. But you can see how it's scarred down. This is all scar tissue. So I'm removing, and the orange stuff is calcium. Yeah, this is an older herniation. That is correct. Dr. Berndes is 100% right. You can age these herniations with the endoscope. Oh, look at that thing. It just popped out of the epidural space. Can you see that, Henry?
Yes, we can.
We're going to go grab it. Okay, we're going to grab it out. Let's get that ruler. Turn the light on. All right, take a look here, Henry. I guess it's going to be about 2.5 millimeters. Nope. Well, let's hope we get it. No, I didn't get it. You have to be delicate here. If I can't get it this time, I'm just going to go back in with the laser. Sorry. I'm going to have to go back in and see why it's not coming out. It could be that it's scarred down to the annulus, annular tear, in which case we may have to do a little releasing. See it right there, the white thing? Oh yeah. Oh yeah. Yeah, it's scarred right there. You guys see that? It's attached right there. So I just had to I got part of it released, but looks like it doesn't want to. Oh, there we go. All right, well, anyway, it's already out. Floated out once I released it. But that's what the release is from the annular tear with the laser. You can't do that with any other tool. You guys saw me reach in there with the pituitary, right? And it didn't work. That's why traditional surgical tools, metal tools, don't work, even if they're microscopic tools. That's a micro pituitary. Okay? Just to give you an idea how big this is that we're looking at. You guys see the laser fiber at 12 o'clock? That is 0.5 millimeter wide, 0.5. That's how small that is. So everything you're seeing here is magnified by the scope. Let's flip. And the laser fiber is 0.5 millimeter. For those of you machinists out there, you like numbers. Again, the orange color is calcium. That's indicating chronic inflammation. And then we get into some bone spur right there. All right. Good. Yes. Any questions?
Yes, we have a question from Lubisa on Facebook.
Hello, Labisa.
They ask, can an annular tear heal after a certain time?
Great question, Labisa. The answer is no. Annular tears do not heal on their own once you have a herniation or a disc bulge. Okay? That means that the blue stuff right here that we're cleaning pushed into the tear and it's holding the tear open. The annular tear will never heal. So that's why people have so much problems with herniated discs, because they actually don't heal. They actually get better for a little while. You'll feel some relief of your symptoms, typically, but then the pain comes back. And the reason the pain comes back is that the tear never healed. This is a perfect example. The tear is trying to heal, and in the process of trying to heal, your body uses the inflammation or inflammatory system to try to heal it. But what happens is that inflammation just causes scar tissue to form. And of course, it causes a lot of pain while the inflammation is going on. So you cannot heal a tear on your own. You need this procedure right here. This is the first of its kind. Nobody has ever done annular debridements. We were the first to do annular debridements with the laser, endoscopically. And it works. It works, number one, to get rid of the pain in the neck, get rid of the arm symptoms, because you're removing the source of the arm symptoms as well. And then, of course, it works to allow the disc to heal normally, like it should, which the disc cannot do as long as that herniations are sitting there. These are still part of the herniation right here. Notice how many pieces of herniation there are. It's not one, it's many. And as we proceed here with this disc, you can see each disc herniation, what we call a disc herniation on the MRI, is actually a collection of many herniations. What we typically find is around 10 to 20, sometimes even 30 or 40 in the lower back. In the neck, it's typically fewer, but still it's a good number. It certainly isn't one. I've never seen a herniation where it's one piece and nothing more. Now that said, I've seen some large herniated fragments, but the herniation is usually around 10 to 20 pieces, sometimes more. All right, great question. What other questions do we have?
This next one is a comment from Trust on YouTube.
Oh, hi Trust, good morning.
They said, my sister has leg pain for years and also arms and hands. Over the years, it's been getting worse and almost bedridden. She no longer drives, many doctors and tests, mostly meds, no answers. I finally got her to request an MRI. She has many herniations in lumbar and cervical.
Well, Trust, hopefully your sister will trust us to fix her. That would be nice, to get her out of pain. I hope we can help her someday. I'm glad you got the test done. Now you just need a diagnosis. That's one thing we could talk about for a moment. A lot of people think the MRI will tell you where your pain is coming from, but it doesn't. There are only two people that can tell you where your pain is coming from. One is the doctor and the other is the patient. But really the patient is the one that's the most important. Patients tell you where pain comes from, not MRIs. MRIs never tell us what causes pain. Unless, of course, you have a normal spine and you have a fracture and that's it, then of course the MRI can be used to tell where the pain's coming from. But the truth is, folks, MRIs do not tell you where pain comes from. When was the last time you heard an MRI talk? And I'm dead serious about that. A lot of people don't know that, and they all think, oh, we'll get an MRI and it'll show us what's causing the pain. Well, if that were true, then everybody would be out of pain. But they're not. And the reason they're not is because the MRI doesn't tell you where the pain comes from. It just shows you things that are abnormal or normal. And it's really the patient and the doctor that have to figure out where the pain actually is coming from. And that's not easy to do, by the way. Not easy to do at all. But it's something we do all the time at Deuk Spine. And if you want to know what is causing your pain, my advice is do one of our free MRI reviews, and we'll put up the address right now. It's mri.deukspine.com. These are all bone spurs, by the way. People ask me, can you get rid of bone spurs? The answer is yes, I can. But this patient and I had a good talk before surgery, and he was showing me some stuff on his MRI. And the first thing I said to him was, listen, we're not here to make your MRI look normal. Nobody can do that. There's no doctor that's going to make your MRI look normal. That's another very important point, something I say all the time. Our job is to get rid of your symptoms. That's what we want to do. And we can do that without making your MRI look normal. As a matter of fact, I don't know a single surgeon in the world that can make an MRI look normal and fix a patient's spine. It's impossible. No matter what you do. I used to make people normal with fusions. I would do a fusion, ACDF. I could still do that and make somebody normal. But your spine's not going to look normal when I'm done. You're going to have metal in there and you're going to have cages. Right, Luis? You're going to look far from normal. So the goal of spine surgery is not to make your spine normal looking on MRI. It's to make it feel normal. And there's a difference there, folks. Functional versus structural. Very important distinction. And I have this conversation with people online all the time. You wouldn't believe how many people insult me on social media, and they have zero training in spine or neurosurgery, and yet they somehow think they know more than a neurosurgeon. Forget about the fact that my specialty is spine, but just that they think they know more than a neurosurgeon about the spine. Which is, I'm sorry, but this generation of people, and it's not just young people, by the way, it's older people too. They have absolutely zero respect or understanding of the training that we go through, the knowledge we possess about things like the spine. Now that said, I'll be the first one to admit there's a lot of bad doctors out there doing bad spine care and with bad results. So I get it, they're angry. They don't trust the doctors, a lot of them, and they shouldn't, by the way. I'm not advocating that you trust the doctor, okay? But I'm just telling you that a spine surgeon knows, a neurosurgeon knows more about the spine than you guys that are not trained to know about the spine. Okay, that's a fact. Now, whether they know enough to fix you, that's a completely different issue. And my point is they don't. They don't. Most neurosurgeons know too little about the spine. They still know more than you, a non-neurosurgeon, but they don't know enough. And that's what we're trying to fix. That's why we do these broadcasts. We broadcast surgery so you can watch. By the way, I'm out in the foramen here. I'm removing herniation and scar tissue around the nerve roots, where this patient has quite a bit of problems here, okay? And we're still on the first disc. We're almost done, but we're gonna move on to the C3-C7 next, I think. Right, Luis?
Yes.
Yeah, it's looking pretty good. I don't see any more herniation. How's the irrigation? Good. Okay. All right. Let's show our next video about how this procedure actually does its job, how it works, how it helps people who have neck pain.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. You can see now how the Deuk laser disc repair procedure works. We've been performing this surgery now 17 years here at Deuk Spine, coming up in June, which is just a month away. It'll be our anniversary. And we have treated over 1,600 patients with the endoscopic Deuk laser disc repair you're currently watching. About 600 on the cervical spine and the rest in the lumbar, a few in the thoracic. We have about 20 patients we've done thoracic. All right, I'm going to remove my tube shot, and you can see it backing out on the x-ray. Meanwhile, I'm stabilizing the dilator so it doesn't move in or out. I don't want it coming out yet. Shot? Okay, perfect. So I'm going to hand off the tube to Luis, my assistant. Watch that, yep. All right. Raytech. Now we've got our x-ray in position. Our goal here is to move down one disc. Shot? Okay. We're going to move south one disc. That'll put us at C3-C7. Let's verify. Go ahead and count. 2, 3, 4, 5, 6, 7. So we're going to move down one disc to C3-C7. So far we've lost about, probably 5 drops of blood. So this is a relatively bloodless surgery. Shot? All right. Let's come out of the disc. And this technique here is the Deuk Spine technique, developed here at Deuk Spine. Shot? We are just outside the disc. Shot? All right, let's get a AP and figure out where our tip is. So on the lateral view, we're heading south. On the AP view, let's see where we are. Quick shot. Good, so we're a little bit off to the right. Shot. All right, let's go back to a lateral. I'm going to make my way down one disc to the next one, the adjacent disc, because we're fixing 4 discs today. All right, here we go. Shot. Shot. Just about there. Shot. Let's get an AP view. I got to make sure I'm in the middle. You're going to want to use lateral and AP views on the X-ray machine. This is called a fluoroscope. This is the new one we talked about a few months ago. That's perfect. I'm right in the middle. Let's go back to a lateral. So I'm exactly where I want to be on the front back view in the middle of the spine. And now I just need to get over the disc. Because his soft, don't move anything. Just a little extension if anything. You're pushing my needle, my tip. All right, I'm entering the annulus. And now I'm going to just head to the back of the disc. Shot. You can relax, Berndes. Thank you. I'm going to get in the middle first and do a discogram. All right, that looks good. Take that. I'm going to clean out this little hole in the middle of my dilator with this pipe cleaner. We call it the pipe cleaner. It's actually a guide wire. Shot. There it is. Good. So I'm inside the disc. Let me go a little bit further. Shot. All right, that's good. We're going to do our discogram. This is not like the lumbar where we do an evocative. This is just a we call it a chromodiscogram. It's color. That looks good. We got a nice blush. I'm going to advance this. I need a little shoulder pull. Just a slight little shoulder thing. Shot. That's really good. Actually, it's nice. I'm going to go further back, shot. I want to get to the back of this disc. This disc is under a lot of pressure. I can feel it. It's pushing me back. So what that means is there's a lot of inflammation going on, which is not a surprise. Shot. Okay. When the disc is swollen because of inflammation, like you guys saw in the video a few minutes ago, shot. Because the disc is so swollen from inflammation, it's under pressure, a lot of pressure. So anything entering it, it's going to try to get rid of that, whatever that is. Shot? All right. So it's trying to push my dilator out, which is something we see quite often actually in these surgeries, because we're treating, after all, we're treating an inflamed disc, right? Shot? Now you keep an eye on that dilator tip. It's moving back already. Shot? Hold that. It wants to come out. Shot? If anything, extension, no flexion. All right. And just give me a minute and I'll take some more questions, but let me focus right now on this. Wait, because it's a bit challenging. And shot. All right. Shot. Oh, good. All right, so I don't want to biopsy the disc. When you see the tube and the dilator in that configuration, if you keep going with the tube, you're going to just cut out a piece of the back of the disc. You don't want to do that. We're here to remove herniation, bone spur, scar tissue, calcium, but not biopsy the disc. Shot? That should be it right there. I can't go any further, so that's perfect. Right there. Shot. Oh yeah, look at that. Show us the tip of this tube where we're going to be working. Okay? You see that right there? And then show us where the spinal cord is, literally right next to it, all right? And that's where the spinal cord and nerves are. And count 2, 3, 4, 5, 6, 7. So I count throughout a surgery around 10 times at least, because I want to make 100% sure that I'm at the right place. Can you pull it up a little? It feels like my mask is coming down.
Just down on that side. Is that better?
Yeah. Yeah, thanks. Okay. Any questions for our team?
Yes, we have a question from Neil on Facebook.
Yep.
They asked, how long is the recovery, and how much shorter term recovery is it than this open spine surgery?
So Neil, check this out. It's going to blow you away. The recovery is 1 hour. Literally, when we're done, and I say we're done, this patient's going to wake up, go to recovery for less than an hour, 45 minutes, and then go home. This is outpatient surgery. And this patient could go back to work tomorrow if he wanted to. We don't make people go back to work the next day, but a lot of people want to go back to work the next day because they got bills to pay, or they love their job like me. So yeah, 1 day. 1 day, I guess you can call it, less than 1 day. We have a lot of patients going back to work less than 24 hours after their surgery's done. There's a piece of herniation right there. So already we've got one. I'm going to pull that thing out. Light on. Let's see if I can get it this time. I got part of it. Let me just show it to you. Can you guys see this? It's not big. It's about 2.5 millimeters. Yeah, it's about 3 millimeters. Can you guys see it?
Yes, we can.
Awesome. Go ahead, Luis. Sorry. Anyway, that's what this surgery does. We basically remove the pieces of herniation at the back of the disc where they're causing problems. We remove them one little fragment at a time. And I don't know how many fragments there will be in this disc, but that's the first. Boy, there's a lot of scar tissue right here. You see all that? The blue stuff is the nucleus pulposus, stained with our special dye, the Deuk spine dye. Oh, there's another herniation right there. You see that blue thing? And again, oh, there's another. Whoa, what happened? I think we got some water. Oh yeah, I got some water in there. Sorry about that. I'm gonna have to scope light on. So we basically got some water between the camera and the scope. So it's kind of nice if you watch, Henry. I could show you how we clean this. You basically disengage the scope from the camera from the endoscope, and then you got to go in between and dry it up, because that water that gets in there from the irrigation will completely change this optical pathway. All right, that should be good. And now we'll reconnect the scope to the camera. But you can see the components here that we're dealing with. And I wonder if we can put something here so that it doesn't get into the camera. I know you did that before, Luis, right?
Yeah, I did it before. Yeah.
And it seemed to not be a bad idea if I can get it to work. Okay, well, let's see.
Thank you very much. Thank you.
All right, back in. There is the herniation. So why did I go back in? I should have grabbed it out. Once again, you alternate between lasering and then removing the free fragments, the pieces. Okay, take it. Any other questions?
Yes, next question comes from Lubisa, once more on Facebook.
Sure. Hi, Lovisa. Happy to answer your questions for you.
They ask, what happens to the facets that continue to bear stress since the disc has been reduced even after the operation? Whether the facets are painful or pain from the disc passes to the facets. My spine hurts to touch like a bruise, and
There's another herniation.
and I suspect it has facets.
Yeah. So Lubisa, great question. First of all, what a lot of people don't understand, we're not removing disc. We're removing herniation. And just so you understand the difference, the herniation was part of the disc, but it left. All right, it left the disc a while ago, and it went into the tear and then into the epidural space. So the herniations we're removing are not part of the disc anymore. They've already taken off. They've already declared themselves as being bad. We're just taking out the trash, Labisa. That's really what it's all about, to be quite honest with you. Oh, there's another herniation right there. So you see, we're not taking the disc out. We're not taking any of the disc out. We're taking the herniation out. Oh man, that was a good one right there. Wow, incredible. Okay. This is all herniation. It's the jelly from the center of the disc that's squeezed itself out through a tear in the back of the disc. And it did that, a long time ago. Not today. We're just cleaning it up. So we don't remove any disc. We're not making the disc collapse in any way. We are taking out the painful part of the disc. It's a great question, though. A lot of people don't understand that concept. We get that question often. And it's a great question because, hey, I would ask the same thing. The good news is we're leaving his disc there so that it can function. And we're leaving his facets there. When you get a fusion done instead, which is the most common other surgery done, you're actually fusing the facets, so they're no longer moving. But then the patient loses their movement. Here's another piece right here. You guys want to see it? Light on. Henry, you see this?
Yes, we do.
So again, this is just one piece after another. That's about a 2 millimeter piece. So it's just a collection of herniations we're removing, a couple at a time, if we're lucky. And the reason these herniations don't just fly out of here on their own is because they're scarred down. And the reason they're scarred down is because, the herniation causes inflammation, which then causes scar tissue. The scar tissue comes from your body attacking that herniation, trying to get rid of it. So the facets are going to be normal after the surgery, is what I'm saying. We're not touching them. We're not affecting them. Now, you're right. If we took the disc out, if we did a discectomy, it would be a different story. Any other questions?
Yes, we have another question from Trust, once more on YouTube.
I trust.
They asked, can herniation cause incontinence?
Can herniation cause incontinence? Yes, it can, if it's in the right place. Generally, herniations, for them to cause incontinence, there's a couple of ways they can do it. Number one, pushing on your spinal cord in your neck or thoracic spine. That's the most common cause. Number two, in your lower back, if they're pinching on nerves, really, really bad, you'd have what's called the cauda equina syndrome, and they would be pushing on your nerves going down your legs. And then, of course, another possibility is indirectly causing incontinence by, well, if you have let's just say you have what's called a neurogenic bladder. It doesn't empty properly. You collect urine in there and it stays in there for too long. You get an infection of your bladder, which can then cause incontinence. So there are many ways that a herniated disc can cause incontinence. And finally, if you're taking pain meds, well, those pain meds can cause incontinence too. So herniated discs have many ways to cause incontinence, but it's not just one way. Great question. This is all a huge tear in the back of this disc, by the way. And the laser you can see is just working. It's magic. Removing the pieces of herniation beautifully without having to open this patient up. This is why he traveled from Michigan to come here. Okay? He didn't want to be opened up. In Michigan, all they offered him was fusions. And he knew, gosh, there's got to be something better. And he found us in Florida. And he came here to Deuk Spine so that, with his whole family, by the way, they're all watching. And I met them. There's a herniation right there. You see that? Coming out of the foramen. That's on the right side at C6-7. That would be pushing on the C7 nerve root, which is your triceps nerve. Goes to your triceps muscles and your brachioradialis. And it would cause weakness of the triceps. This is the annular tear that I'm debriding, hoping that this will heal after we're done. I got to clean it up a little so it'll heal properly. Great questions from the audience today. Keep asking. I'm happy to answer them for you.
Next question comes from Truth Always on YouTube.
All right, Truth.
They asked, what happens to the disc when spondylitis happens and disc height is absent?
There's another herniation. You see that? What happens to the disc once spondylosis occurs and the disc height is gone? Well, the disc collapses. It doesn't do anything. It just collapses. And we don't treat that. Nobody should ever treat a collapsed disc that doesn't cause symptoms. If the collapsed disc causes no symptoms, don't treat it. If the collapsed disc does cause symptoms, then this is the treatment you want. Laser, endoscopic. So it comes back to the age-old question, to treat or not to treat. And the only time a spine surgeon should be treating is when the patient has symptoms. And if you don't have symptoms, you don't treat. So, to answer your question, if your disc is collapsed and you're having symptoms, this is what you want done. How does this surgery take away symptoms? By doing exactly what you see, getting rid of the source of inflammation. And if need be, taking the pressure off the nerves that are being pinched. You're watching it in action. Let's run the video one more time showing how the Deuk laser disc repair works. These are all fragments of herniation. How many of you counted?
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. You see how the herniated disc cause neck pain and arm symptoms. It's from inflammation. Speaking of which, that is the nerve going in the arm right there. That's the C7 nerve root. And that's the dura, or covering over the nerve root. It's white. It's supposed to be white, but in this case, it's red. Why is it red? It's inflamed. And there's a little vein right there running in the sulcus. Did you get that, Henry? You get a picture?
Yep, all good.
All right, there's a perfect example of what the video just showed you. Inflammation of the nerve root. Go back and watch it again. When the back of the disc has a herniation, they get all this inflammation going, and that inflammation spreads to the nerves and causes arm symptoms. God damn it. Come on, man, get the laser working. Surgery is hard enough with the equipment working. Let's get it working. All right, any other questions?
Yes, this comes from Talon on YouTube.
By the way, for those of you wondering, spine surgery is not like fishing or doing anything else. You have a person's life right in your hands, so, and it's a team approach. So when things aren't working properly, it's not like you lost a fish, or maybe you put too much grout on some tile. You have a person's life at risk. So it can be a bit stressful at times. But that's why I need my team on their A game throughout the whole surgery. Once they come off the A game, things start going to hell in a handbasket. And I have to prevent that from happening. All right. What's the next question? So you guys see the foramen? The nerve root's totally decompressed. That's the right C6-7. Now we got to flip and come around and go to the other side. All scar tissue. Yeah, go ahead.
Next question comes from Talon on YouTube, and they asked,
Big herniation right there. You guys see it?
yes, we
That's
do.
a 3.5. 3.5 millimeters, maybe 4 millimeters.
Lights on, please.
So many herniations, and you can see the tear. That's what I've been working on. Let's see, there it is. Oh, that's a biggie. Take a look at this thing, guys. Can you see this? Turn the light on. Okay, when I come out, it's a signal for you to turn that light on every single time. It's like, don't even make me ask you. I got to stop surgery and tell you, you should see me coming out, turn the light on. That's your job. Okay, can you angle the light down, please? All right, let's take a look at this herniation. That's a good one. That's a good, actually 5 millimeters. Good 5 millimeters. Now most men don't brag about 5 millimeters, but when you're doing spine surgery, you got to. You got to take it. Maybe even 6 millimeters. See that? All right, so that just came out from the epidural space behind the disc, pushing on the spinal cord. That's what we're here for. So far we've taken out quite a bit, and it's a little bit a little bloody because there's so much inflammation, okay, in the back of the disc. Look at all that inflammatory tissue. None of that is normal. All of it's abnormal. Shouldn't be there, basically. All right, let's keep going. All right, I'll take that question.
Next question from Talon on YouTube. They asked, I'm living in Europe and I cannot find anyone to do a surgery like you are doing. If I send in an MRI tomography images, can you plan an operation without examinations face to face so that I can come over only for the operation and go back to my job?
Hi, Talon. Nice to meet you. That's exactly what we do here at Deuk Spine, Talon. We do MRI review over Zoom, where I look at your MRI and figure out what's wrong. And then I plan out your operation over Zoom. It takes me 10 minutes. That's all it takes. So we're happy to do that. Henry will give you the link, and you can upload your MRI and answer some questions so we have a little background information on you, your problem. But if you have a back problem, you have a neck problem, you have a thoracic problem, we fix all of them with laser endoscopic spine surgery at Deuk Spine Institute. By the way, we are the only ones in the world that do this, just so you understand. It's not like you just happen to be living in a vacuum over there. We all live in a vacuum. That's why we're trying to show people this technology, because their surgeons will never show them this because they don't do it. And their surgeons want these patients to have fusions or artificial discs. They may start with a laminectomy or a microdiscectomy or something, but ultimately they're going to take you to a fusion. And along the way, you're going to spend a lot of money and a lot of time fighting pain with treatments that don't work. This is the ultimate treatment. By the way, look down there, pretty cool. This is all scar tissue from the annular tear. The white stuff I'm zapping, but below it is, that's the dura right there on top of the spinal cord. There's a little bit of posterior longitudinal ligament. I'm pulling it aside, but that's the spinal cord right there, the cervical spinal cord at C6-7. You can see how precise this is. Now the laser fiber is 0.5 millimeter, 0.5 millimeter wide. And the laser only goes out from the tip about 0.5 millimeter. So you can see it just doesn't shoot around like in Star Wars, where they're shooting lasers everywhere. This is a controlled laser. It's a medical laser, all FDA approved. It's called a holmium YAG laser. And the YAG stands for yttrium, argon, and garnet. The laser itself is FDA approved, but it's made in Israel. And they make amazing stuff in Israel, obviously, in my opinion. Sorry for all the Muslims out there that disagree, but in the end, they do. They make great stuff. And this is their laser. So we bought it, and we're using it to clean people's discs and repair their discs. Okay? All right. So far, this surgery is going very well, not having any problems. But we do take a lot of patients from Europe, mostly from England, Canada. Canada's not Europe, obviously, but we get a lot from Canada. We have a lot from South America. And, of course, from America, from the United States of America, we have a lot of patients. We had a patient from Brazil, right. He was here Thursday, right? Yeah, he came for his thoracic disc herniation. And he said that, this is what he told me. First of all, he's here because he was having horrible thoracic pain. It was like a knife in his back, right by his shoulder blades. So we did our telemed, and he came, and he said to me, there's only one surgeon in all of South America who does thoracic surgery, thoracic spine surgery. And he told me that if he did my surgery, it was 98% chance it won't work. And there's a 35% chance I'll be paralyzed from the surgery. And I said, geez, no wonder why you came here. We've never had a complication in 17 years of doing this. You can see everything quite nicely as long as you know what you're doing as a surgeon. You have to be a good surgeon to do this. And I started doing spine surgery with ACDF, PCDF, laminectomy, foraminotomy, everything invasive and open. And I got very good at those surgeries, and somebody said to me, you should go learn endoscopic. That was my wife, actually. And I told her, you think so? And she said yes. So I listened to her, and here I am now doing endoscopic surgery on patients from all over the world because they can't find it anywhere else. And it's true, you can't. The problem, folks, I'm going to be honest with you, is you know how Facebook controls a lot of social media, Meta, and so does Twitter? There's a few companies that control most of the social media. Well, it's the same thing in spine. There's a few companies that control spine around the world. And those companies want surgeons doing fusions. That's how they make their money. They sell the metal that's used for the fusions. So anytime we don't do a fusion, they're losing money. And they don't want this surgery out there at all. They don't want it. They're totally against it. And every time I go out and teach the surgery, they try to keep doctors from coming and hearing. Now, the reality is that the fusions do pay better to the surgeon. Surgeon makes more money doing fusions. So that's another reason the surgeons are doing fusions and artificial discs, is they make a lot more money for doing it. I can't get that herniation out. But that's the last herniation at this disc. We're going to move on to the next.
Stop off, please. Thank you.
There it is. All right, we're done. Scope off. So that's 2 discs fixed, 2 more to go. I'm going to put some antiseptic. This is called betadine. It was developed by NASA, the space agency in the United States, for basically processing samples that they didn't want to bring back any space heebie-jeebies, any space gunk, right? No viruses or little. Anybody see the movie called Prometheus? They didn't want to bring back any of the Promethei. No, that was the ship, but.
It doesn't work on prions, right?
Huh?
It doesn't work on prions, though. The betadine doesn't work on prions?
I don't know. I don't know. I don't think it works on prions. No, but it works on. I mean, it's the best we could do, right? It's the best we could do. So anyway, we use it as an irrigant. The reason why there's a little bit of bleeding, remember I showed you all the inflammation going on down there. Basically, that inflammation is your body attacking the herniation, attacking, trying to get rid of it so the disc will heal. It wants the disc to heal. Your body wants to heal the annular tear. It just cannot while there's the fragments in there. You see how big the fragments are. You see how small the tear is. There's no vascularity. It's very minimal. So you don't have much of a chance of winning that battle against the herniation. It's like having a splinter in your finger of wood. You can't, your inflammation attacks the splinter, but you can't get rid of it. It's going to stay there for many, many years. Now the difference is the splinter gets covered with scar tissue, so it doesn't really hurt you after a while, but the nucleus doesn't get covered in scar tissue because people keep re-injuring it. So it keeps ripping the scar tissue and starting the inflammation cycle again. All right, let's go to, that's it, that's where we are, shot. All right, beautiful. We're going to take this out and leave the dilator. I need a little shoulder pull. Show me. Okay, good. So you see how I'm holding the dilator with my finger? I am not letting it come backwards or forwards, but I'm wiggling out the tube. Shot. And once I get this tube completely out of the disc, it'll be easier to get rid of it and take it out. Shot. Almost there. Again, I got to hold the dilator in place while I wiggle out this tube. Almost done. But as a surgeon, you cannot let the dilator come out, shot, and you cannot let it go in. All right, I'm having some resistance. I think I'm shot. I think I'm like stuck on the thyroid cartilage or something. Shot. All right, I don't want that going in. Shot. What's happening is the dilator is getting trapped by the tube, which is slightly, it's not coming straight back. Very interesting. So you get to see how we deal with issues. Shot. Shot. All right, I've got to keep the dilator in the disc. Almost there. There it is. Shot. Let's just check. Bring me a ray in case I need it. And we're out. So it was just kind of stuck on the skin edge. Shot. Yeah, that's good. I think it was stuck on the skin edge and the clavicle. All right, so here we are, ready to do our next disc shot. To do it, I have to come out of this disc and head north. That's what we're going to do now. Shot. Almost there. There we are. We're out. Shot. Okay, now I got to make sure I'm in the middle, AP, because you don't want to get off the spine. If you get off the spine, left or right, you fall off, you're in trouble. You need to start over again. And that's going to be hard to do because of all the swelling. Shot. Shot. I think I went into the hole. Lateral. Let's see where we are. Yeah, I went into my pushed myself back into the neck disc above. So, and that hole will close. It's just a spreading of the annulus. I got to come out. Shot. I'm out. All right. Now you can you have to feel these things, by the way. As a surgeon, it's not just led by vision. What you're seeing, you have to feel too. So that makes it challenging. Yeah, I'm off to the patient's right too much. All right, there we go. That should be better. Yeah, it's a little better. I feel like I'm at the next disc. Shot. That's good. Let's see where we are on the lateral. That's really nice. on the AP view. Let's get to a lateral view. Again, you're watching me use the X-ray machine to navigate and localize. All right, so 2, 3, 4, 5. It's the next disc up. Everyone agrees? Yes? Shot? I got to get over this hump. Shot? Interesting. I don't want to go there. Shot? So started to slip off the vertebral body to the patient's right. I just wanted to put it back and we'll see where we are. Shot? That's good. Stay there. I'm going to move a little bit north and then I'll get another AP view. Shot? Yeah. Let's get a lateral. By the way, for those of you wondering, I am using gloves that partially block the X-rays to my hands. If I didn't, I would be getting a lot of radiation to my hands, and then it would be bad for me, really bad for me. Shot? So unfortunately, spine surgery is shot. It's a type of specialty where you can harm yourself as a surgeon quite a bit if you're not careful. You can get too much radiation, for example, or you can get a needle stick. Shot? Okay, so a little bit too far to the right. I need to come back to the patient's left and shot. Probably want to come back a smidgen more. Shot? Perfect. Let's go lateral. Let's verify. I'll need my mask pulled up just a little bit again. So you can see the tip of the dilator is at the spinous process. It's perfect. That's where we want to be. We're also on the lateral view, kind of in the middle of the disc in the front. I'm going to tap in as opposed to tapping out. Shot. I felt myself in the disc. That's perfect. Take that. I'm going to pipe. I think we're fine. We'll clean out the core. Shot. Shot. Make sure there's no shot. Nucleus in there. We'll do our discogram. Still got pretty good hands. Shot. All right, you can see the tear in back of the annulus. Shot again. Shot. Show them the tear. It's actually developed nicely. All right, get ready to take a shot. I'm going to give you a little more. And shot. All right, so that's probably as good as we're going to get it. You can see the tear there. Yep, great. I'm going to advance this dilator to the tear and through the tear. Shot. Very good. So we're right where we need to be. Put the tube over. Any questions? Shot. Okay.
Yes, we have another question. We have another question from Truss once more on YouTube.
All right, before we do that, I want you guys to notice that we have fixed 2 discs already with the same incision. It's 4 millimeters. We're going to start the third one in just a second here. Shot. I want to bring, can you pull that up? Just, yeah, pull both sides up. There you go. Perfect. That's good. Thank you. Yeah, I think I tied the string on the bottom too tight compared to the one on top, which is looser. Nope, I'm good. Thank you. Great. So you can see we're going to enter. We're going to advance the tube to the back of the disc along the dilator. By the way, this does not take any of the disc out. All it does is slide through the disc. Remember, the center of your disc is a liquidy, not liquid, it's really a kind of a semi-solid material called the nucleus pulposus. And it's really, if you understand biochemistry, it's made up of what are called proteoglycans, which are basically sugar chains with little protein heads. And they basically provide a nice hydraulic cushion for your disc. Like when there's a force, lifting, headbutting, wrestling, whatever, sports, work, your spine takes these shocks, and that energy, if it was just bones, it would fracture the bone. So you have to have these cushions in between the bones. Quite an ingenious design. Can't take credit for it myself, but those cushions in between the bones are called discs, and it's really the nucleus pulposus that absorbs the shock and distributes that energy throughout the nucleus and against the wall of the annulus. The annulus's job is to hold the nucleus in place and hold the bones in place. So when you have too much trauma, when the forces are greater than the capacity, the elastic capacity of the disc, then you get a fracture of the annulus or annular tear, and you get a fragmentation of the nucleus pulposus next to the fracture. So you get two things happening. The nucleus is broken into pieces, and the annulus is torn open. And now fragments of herniation can literally escape from your disc. And that's what happens. The broken nucleus next to the annular tear squeezes into the annular tear, and then it starts inflammation, starts an inflammatory reaction, which of course, we're not doing that. Which of course the inflammatory reaction is what causes all the neck pain, and of course the nerve root pain. So that's what we saw in the video earlier, is a video explaining that inflammation. Now we're the first to do that, to explain this process completely here at Deuk Spine, first in the world. There have been pioneers, though, whose shoulders I've stood on to figure it all out. People like Dr. Rauschning. If you know Dr. Rauschning or his work, he is a spinal anatomist, orthopedic anatomist, and he did a lot of these sectioning of the human body. This was before CAT scans and MRIs. And he would literally cut open dead people and look at their discs, facet joints. And Dr. Rauschning published some images that the early surgeons some of them took notice of, including my mentor, Dr. Anthony Young. And of course, he taught me. And you could see in these discs from Rauschning that patients who had back pain for years, they had these tears in the back of their discs, and those tears had inflammation in them, granulation tissue, all right, inflammatory tissue, just like we're seeing here, scar tissue and nucleus and hypertrophied annulus, torn annulus. So the early work was done by anatomists like Dr. Rauschning, who went around the world teaching surgeons, spine doctors like my mentor, and eventually me, because I actually heard him speak once. This was back in 2008. And he taught us, about inflammation in the disc. But as far as nobody was ever able to prove that the inflammation was the cause of pain until we started treating the inflammation at Deuk Spine with our Deuk laser disc repair. And as we eliminated the herniation, which every surgeon tries to do, we were also cleaning up the scar tissue and inflammatory tissue. And lo and behold, we discovered back pain went away, neck pain went away. So that's all we're doing, removing the herniation and removing the inflammatory tissue. So then you started to ask yourself, well, but other surgeons remove the herniation with their surgeries. So why can't they get rid of neck pain or back pain? And the answer was because that's all they're doing is removing the herniation. They're not treating the inflammation that's going on there. See, we're the first to do that. And as a result, with the Deuk laser disc repair, treating the inflammation, we got rid of back pain, neck pain, thoracic pain, and we've been big advocates for this procedure now for years. And we do our YouTube, we do our Facebook, we do our website. We have a new website coming soon. The problem is I'm a perfectionist and I cannot release the website without it being as close to perfect as humanly possible. So that's me. My, what do you call it? My son would say my autism, but my compulsive side of my behavior, wanting to perfect things, which is not a bad thing to do, to be honest. I guess it got me here. All right, any questions from our audience?
One.
All right.
Our next question comes from Trust on YouTube.
What a
and-
surprise. Trust never asks questions.
And they asked, not sure what it's called when the disc had a loss of moisture, but can it be treated with this procedure?
Thank you, Trust. So when the disc loses the moisture, it's called desiccation, spelled Dessiccation. And that's the common term used in the business, desiccation. The answer is no, it doesn't, it cannot be treated currently. And it, what? Yeah, thank you. I was wondering. And more importantly, Trust, it doesn't need to be treated. Unfortunately, I get it. All right, I get it. Here's all these people who are suffering from spine problems, back pain, neck pain, and their doctors have failed them. So they feel like, well, my doctor failed me. They couldn't fix it, so let me try to fix it, right? And I get it. You guys want to try to solve all the problems, but you can't because you're not a surgeon. And I mean that in an endearing way, not a negative way, but the only way to fix these disc problems is with surgery today, in 2023. And it takes somebody like me who doesn't just go in and do surgery blindly, but who's studying my results, trying to figure out how I can make it better. That's what you need. You need a champion, a hero, someone who comes along and solves your problem for you, okay? But it can't be just somebody who's reading books and coming up with theories. Because the problem is all the information you guys have is inaccurate. Because we've been wrong as doctors, and we're the ones who write the books. So if medicine has been wrong for all these years, then you're trying to solve a problem that is basically given to you on a silver platter, but it's a wrong problem. The goal is not to add hydration to your disc. The goal is to get rid of your symptoms and have a normal functioning life. That's really the goal. So, but because the doctors fail to do their job of doing that for you and giving you guys a solution, now people have taken it in their own hands, right? It's like vigilante style, and I don't blame you, by the way. I would probably want to do the same thing if the medicine failed me. I would try to solve it myself, but I'm just telling you, I've been able to solve it for you, and it's taken every bit of knowledge and experience and resources, and I've spent millions and millions of dollars on this, by the way, to come up with a solution. So it's great that you guys want to participate. I love it. But I can tell you right now, the answer is not in rehydrating a disc. The answer is really in the inflammation happening at the back of the disc, which there's only one way to get rid of it, and that's to, well, there's a couple of possibilities. Get rid of your inflammatory system. Not going to happen, and you need it. Number two, get rid of the blood supply to your disc. Bad idea. The disc already doesn't have enough blood supply. You don't want to take away more. You'll starve it. It'll die. And then number three, do the Deuk laser disc repair. What we're actually doing today. This is it, folks. This is the very best that humans can do. Will there be a better way in the future? Probably. I would imagine. I mean, I can't imagine my creation is going to be the end all, the be all for back and neck pain. I mean, somebody will come up with something better sometime in the future, I'm sure. because I'm not the smartest person in the world, and somebody will figure out a better solution. But you cannot come up with solutions unless you understand the problem, okay? And that's what I'm trying to teach you all, is the problem. So you guys, if you want to come up with better solutions, go for it. And the problem, I assure you, is not hydration of the disc. That is not the problem. The dehydration of the disc, or we call it desiccation, is a result of chronic inflammation destroying the nucleus pulposus. It is the nucleus pulposus that is dehydrated or desiccated, not anything else. Remember, the disc is simple. It has a very simple structure. So what's dried out is the nucleus pulposus, and nothing more than the nucleus pulposus. So to suggest that rehydrating the nucleus pulposus would fix the problem is ignoring the problem, actually. The problem being inflammation within the annular tear caused by, oh yeah, big one. Let's turn the light on. You can always tell when the big ones are coming out because it creates like a suction in the, I got a blue towel, we're good. It creates a suction in the tube as it comes out. That's a biggie. That's another biggie. Can you guys see that? Let's clean up the blood.
Yes, we can.
All right, thank you. We'll use it as a mop first. And there it is, right there. There's a piece of herniation. That's what they look like, folks. And they're firm. It's like almost like a piece of cartilage, you know, if you've ever eaten cartilage off your steak. That's a good 6 millimeters. But we're going to keep taking these out until they're all gone. Like I said, the patient traveled all the way from Michigan with his family, and, you know, they want the best, so we got to give them the best. That's my obligation. It's my duty. Give them the best possible surgery. Give them what they came for. All right, questions.
Yes, we have a lot of questions. This next one comes from Daniel on YouTube.
Daniel?
Yes.
Hi, Daniel. Welcome.
They ask, speaking only in terms of this procedure, what is your brother's dislike about the procedure? I think he is a neurosurgeon too, correct?
Oh, Daniel, I love it. I love it. Well, my brother is a neurosurgeon. You hit the nail on the head. But I will tell you something, folks. When I talk about spine surgeons that put their needs ahead of their patients, I talk about 99% of spine surgeons, and my brother is counted among them. Sorry, it's true. He's a fusion surgeon and an artificial disc surgeon. He's a very good surgeon, but he's tied to the old ways. And he was trained in the University of South Florida, Department of Neurosurgery, and that Department of Neurosurgery was not a top neurosurgery program, ever. And he was trained by, he got kind of lucky because one of the newer technologies in fusion, which I don't recommend ever, by the way, is called the XLIF, X-L-I-F, fusion in the lumbar spine. And the pioneer who discovered this technique, kind of like I pioneered the Deuk laser disc repair, his name is Luis Pimenta. He's from South America. And he figured out, hey, why go through the back? Why go through the front to get to the lumbar spine? Let's go through the side. Forget the back, forget the front, go to the side. All right. And he found a way to go from the side. It's great. The problem is that surgery causes nerve damage during the surgery. I mean, literally, and everybody accepts it. And the reason why they accept that nerve damage, the surgeons do at least, is because their feeling is, well, but you could have other complications going through the back or through the belly. And they're right. Going through the belly has its own complications too, which can happen. But the problem is the XLIF, 100% virtually of patients they lose the ability to lift their leg. And they can't walk for a while. Now, have there been improvements in the technique over the years? Yes. But the point I'm getting at is one of Dr. Pimenta's students is a neurosurgeon who happened to be on faculty at the University of South Florida. His name is Juan Uribe. And Dr. Uribe was one of my brother's chief mentors, and my brother published papers with him. And more importantly, they had a profound influence on my brother in terms of convincing him that, you know, invasive surgeries are the way to go, basically. So that's what he learned. That's what he stuck with, and he's very good. He's a very good invasive surgeon, okay? He's not a minimally invasive surgeon like me. I evolved over time. I got what I think is better with this technology. I became a better surgeon for my patients. But he's in Tampa, and he's a very good spine surgeon, but he does the invasive stuff. And honestly, he makes a lot more money than I do. His salary is much higher than mine. He gets paid well for the invasive surgeries. But I will tell you this, and it's true for all the surgeons doing invasive surgeries like fusions. They're all going to get paid better. But someday, people are going to stop doing it. They're going to realize that that's not the way to go. And those doctors are all going to end up phasing themselves out. They're all going to become what we call obsolete. And you know what? That's fine with me. I'm not going to become obsolete. We're still making progress here at Deuk Spine. We're creating new technologies, new techniques. We're fixing problems that have been around for 1,000 years. Actually longer than 1,000 years, I should say. Maybe millions of years, right? Ever since humans have been walking the earth, I'm sure there have been back pain from a disc problem. Discs have been around a long time. So,
That's why the Cro-Magnons never walked upright.
yeah, that's why the Cro-Magnons never walked upright. Yeah. So the point is, I'm very happy with the choices I've made about how I am a doctor and how I take care of my patients. And I know my brother is happy too. Does he have an opinion about the surgery? No, he doesn't. I don't even talk to him about it. He's got his own practice, and, you know, we're both two very well-trained and opinionated doctors, and so that's it. You know, that's all I can say. He doesn't do the endoscopic surgery. And honestly, I wouldn't teach it to him anymore anyway. Luis is laughing, but he's right. It is somewhat humorous, but the person I would teach is my son and my daughter. I think they're going to make great surgeons someday. All right. Just about done. So just to bring everybody up to speed, and I'll take some more questions, we are finishing the number 4-5 disc, 4-5. We've already finished 5-6, 6-7. This is a giant ball of scar tissue, for those of you who don't know. And I looked at it and I thought, you know, should I leave it? Because scar tissue itself is not always a problem unless you have herniation stuck in there. And I'm looking to see if there's any herniation. I don't see any. Scar tissue is actually collagen, and it's your body's attempt to heal. So scar tissue itself is not always bad. It's actually natural. It's the way the body heals naturally. And this one here seems to be not doing anything active. So I think I'm going to leave it alone. I don't want to stir up the hornet's nest. There's a little bone spur there I've been working on. There we go. Now it's gone. So for those of you who wonder, can you get rid of bone spurs? I just did. That was a bone spur. That's right where the nerve is, by the way. It's gone now. And I think we're done here. We're going to do one more disc, and we'll be done. I'll take some more questions.
Next question comes from Jessica on YouTube.
Hello, Jessica, on YouTube.
They ask, I have a herniated disc at L3-4, 4-5, and S1, and I've been suffering for a year. It's taking my life from me. I'm a mother, wife, and always active. Gym every day, hikes with kids, and outdoors.
So sorry to hear that.
I live in Wellington, Florida. How many surgeries like this have you performed, and what's the recovery rate? And was there any reoccurrence of the herniation in the disc treated?
Wow, that's a loaded one. So how long have I been doing this? Well, I just started today. I was staying in a Holiday Inn Express last night. Just kidding. I should get money for that. I've been doing this surgery you're watching for 17 years almost. We've done 1,600 plus. We stopped counting. And we do them every week. We've never had a complication from this surgery. Never. Not a single complication. So it's the safest spine surgery in the world with 0 complications. Also, patients don't need painkillers after this surgery. In other words, we don't need to give them any new painkillers. Of course, if they come here on painkillers, they can't just stop. Otherwise, they'll go through withdrawals, right? So you don't want your patients to go through withdrawals. This part, I'm going to try to get 3-4. We may have to give a little more muscle relaxation, maybe. So just be prepared, but don't do it yet. All right, no, don't do that. Let me show you guys. And I don't know if I answered all of Jessica's questions, but no complications to date in 17 years, over 1,600 of these surgeries done. It's a permanent fix, Jessica. You come in, 1 hour surgery, leave an hour later, and go back to your normal life, except you'll have some restrictions for 1 year. And those restrictions are no lifting over 40 pounds, no bending at the waist to pick anything up for 3 months. You got to walk every day to stretch your back, but that's it, okay? So that's the best in the world for you right there. And the reherniation rate with these surgeries is 1%. 1 out of every 100 patients will reherniate. I can tell you it's always because they do something they're not supposed to do. And they come back, you know, like 6 weeks later, oh, I felt a pop in my back when I was lifting something, or I knew I shouldn't have been doing this, but I did it. So 1 in 100 will reherniate, and if you just follow the instructions, you will not reherniate. I think I answered all your questions. So let me get back to the surgery. You guys can see the incision. It's 4 millimeters. We're going to do a second one a little bit higher. I just want to hold pressure for a minute, and then I'm going to try to do the next one. I couldn't do all 4. You cannot flex him, right? Don't flex him. Where are we at? Is that it?
Yes, sir.
So I'm too low. I need to be a little bit higher. And I'm fighting him too much.
Give him some more. No problem.
Yeah, so basically, to be able to do the beginning of the surgery, put the needle in, I need all the muscles here relaxed. And he's pretty relaxed, but he's not relaxed enough. So I got to get these muscles to relax, because every time you push against muscles, they pull back against you. They tighten up. And so we need to give him a little bit more muscle relaxer. Meanwhile, I'm just holding pressure on the incision. You can see it's not bleeding. I think we lost maybe, I don't know, 10 drops of blood, which is 1/2 of a cc, or 1/2 of a milliliter. If this surgery had been done elsewhere, he would have lost 500 cc's, 500 milliliters. That's 1/2 of a liter. But here we're going to lose 1/2 of a milliliter. So basically, instead of losing 500, we're going to lose 1 if you round up. This surgery is bloodless. It's scar tissue-less. Patients don't have any trouble with their swallowing, except from the tube being down. And yeah, I mean, immediate relief usually everybody gets. Next question. Let me know when I can proceed.
These next questions come from Darren on Facebook.
All right.
Takes about 70 seconds.
He asked, would the pain from a herniated disc come and go, and why? And how many discs can you reasonably correct in one DLDR?
Yeah, great question. So why does the pain from a disc come and go? The answer is because people aggravate it and set off the inflammation. Okay, shot? Shot? I think I need to be a little bit more north. I'm going to give it just another minute.
Want it in line with a little extension, no flexion.
I want slight extension, slight extension and pull. So inline, distraction and extension, not flexion. Flexion will bring the jaw to my finger.
Yeah.
I don't need the shoulders pulled either. I just need this area supple enough for me to get in, and it's feeling better already. No. Shot. Yeah, getting to 3-4 is really tough. Shot. 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 Give me an AP, quickly. Everyone hold, shot, just real quick. Do it now. So too far to the right. Come back. Shot. All right, come back to an AP. Quickly. Right there. All right, that's fine. Let's go lateral. So here's what I'm doing. I'm going to keep my needle on the front of the spine. I'm not quite at 3-4, but I can get there. So I'm going to put my, I'm going to put my guide wire, and then we'll do a little bit of num-num. Take that. And then I'll make my incision. He is going to look like he came to Florida and, what is it, Renfro? Huh? The Chupacabra? He's going to look like Dracula got to him, okay? There's no way around it. He's going to have two small incisions in his neck, and it literally is going to look like he got bitten by Dracula. I'm not ready for it yet. Blood pressure is good?
Yeah. I'm good the whole case. 108.
It's perfect. All right, knife. And I told him that. I said, we're going to have to do 2 incisions. You know, there's no way I can do the 4 discs with just 1. All right, so here we go. I'm going to leave my guide wire. Nobody move. Nobody do anything. I need to leave my guide wire in the front of the spine. Okay. Take off my needle. Dilator. And then I'm going to bring my dilator. I still feel the bone. As long as I'm on the bone, I'm okay. You don't want to lift off. If you lift off, you get into trouble. But just staying down is fine. Shot. We haven't moved. And again, I'm going to hold this guide wire there. Shot. And I'm going to just gently, with oh so much tender care, bring this thing down. Shot. And as soon as I get to the front of the spine, shot, I can take the guide wire out and I can manipulate. Shot. All right, beautiful. So I'm there. I'm going to keep it there. I'm going to get an AP. And then I'm going to, you're watching history, by the way, if you haven't ever, if you didn't know that. There's nobody in the world that's ever done this technique like this. Yes, it's perfect. Let's go lateral. So what I learned from the Koreans was a single disc and this part to get into the disc. So needle, guide wire, incision, dilator, and tube. But one disc, never moving from disc to disc, never going from the front of the spine, the bone, up to the disc. But it just makes sense. And sometimes you have to just do things that make sense because they make sense. And you need to. You need to do it, otherwise you're going to have a problem that you can't solve. So solving problems means making decisions and choices that make sense. Shot. And that's what I just had to do. So I've never had to plant in front of the vertebral body below the disc and move up. I think I've done it once before. Right, Luis?
Yes.
Once before for that patient that had a C7-T1.
Correct.
Shot? All right, so I'm right on the front of the disc, and I want to just start going in through the annulus. Shot? I'm going to get another AP just to make sure. AP, folks, is an anterior posterior picture, front back. I want to stay in the midline. I do not want to deviate from the midline. Yeah. So that's tough because the spine's a little bit rotated there. You see that? I need the spine straight. Just stay there. Straighten it out. Shot. All right. Well, that's not where I want to be. Take that. I'm going to try to move back. Now, I am going into the disc a little bit, so I'm going to have to come back a little, draw back, and try to move. There we go. All right. Shot. That's better. It's a little bit to my side, but it's definitely, how about that? That's perfect. Lateral. You got to be uncompromising if you want perfection. And of course, we never achieve it, but we try to get as close as possible. And when you do, amazing things happen. You get great results that are reproducible, predictable, reliable, and that's what it takes. But you got to have guts if you want to change the world. This is our last disc. So Dr. Berndes, shot, 10 minutes, maybe 15 max, we'll be done.
Less relaxed, I'm gonna have to wait a little bit.
Huh?
Less relaxed is gonna be longer than 15.
No. Shot. I'm sorry.
That's okay.
Not much I can do about it.
I get you. You have to have something.
But it did help, by the way. Shot. Okay, 3-4 was actually pretty herniated. So I know we're doing the right thing for this patient.
The 15-minute muscle relaxant they took off.
Shot. Huh?
The 15-minute muscle relaxant they took off the market was fantastic.
What? Which one?
So Mivacurium, Mivacron,
Shot? Really?
because it cost too much to manufacture and the drug cost was,
Nobody was buying it?
yeah.
We can't get it in Mexico, right?
If you get 15 minutes.
Shot.
Oh, it's FDA approved, it's just not manufactured at all anywhere.
I know, but you're not allowed to buy FDA-approved drugs in other countries.
Right.
I didn't know if you know that.
Yeah.
At least not for
It's not
Medicaid
manufactured
patients.
anywhere.
Shot. The FDA has a chokehold on our medical industry, or not the FDA, the pharmaceutical companies. They lobbied to the FDA saying, hey, these hospitals and doctors are buying drugs, the same drugs we sell here for $1,000. They're buying them for $100 down over in Canada and Mexico. Don't let them do that. And guess what the FDA did? They said, oh, okay. You know, are you going to give me some of that money? Yep. All right. We'll make these doctors and hospitals buy them from you for $1,000. That's how healthcare is, folks. It's corrupt. Corrupt on every corner. The only thing I can do is help you open your eyes to see the truth. All right, any questions for me? We got it. C3-4. Can you pull me up again? Any questions, Henry?
Yes, we have a question from Neil once more on Facebook.
Perfect. That's good. Thank you.
And they asked, does epidural injection make your condition worse and herniated and also burning of the nerve? Does this or worsen your condition? I think it. Hang on, let me, can I repeat that or do you have that understood?
I got it.
Okay.
He's asking if the epidural will make people worse. All right, so here's the answer to your question. Will an epidural make people worse? The answer is, if the epidural is done well, properly, without any kind of complications, it will not make you worse. It will make you feel better for a little while and then the pain will be back. But no, it doesn't make you worse, it doesn't make your disc worse. It just makes you feel better because it reduces the inflammation for a little while. On the other hand, there are people who have been paralyzed getting epidural injections. So the problem is that the government has not regulated doctors well enough And just about anyone, any bumbling idiot with an MD degree or a DO degree can, and maybe even soon a nurse, can actually give you an epidural. And here's the thing. For most patients, it's not a problem. It's easy to do, right? Low risk. But after all, if you think about it, you're sticking a needle in near somebody's spinal cord. So there are complications that can happen. And also you can get an infection. Of course, spinal fluid headaches and all things like that. So in my opinion, number one, here's the thing. There's going to be a day in the future when we stop screwing around in healthcare with treatments that don't work. And we're going to stop doing them. And the only time somebody will get an epidural in that world, in that future, is like, let's say you're a teacher and you've got another 2 months before summer break and you're going to get spine surgery and you're having a lot of pain. Well, then you go get an epidural. Those are all fragments, by the way, coming out of the epidural space where they shouldn't be. Those are all herniated fragments. Okay, they shouldn't be down there. They're past the back of the bone. This is the back of the bone right here. All right? So they shouldn't be there. This is a herniation, C3-4. The only time that we'll be doing the epidurals, if we do the right thing for patients and the insurance companies, to be quite honest with you, and everybody, will be when you have a teacher who needs another 2 months before school's out, or you have somebody who can't have surgery right then and there, and they just need to buy some time and feel better so they can function. That's when we'll do epidurals. We'll recognize that they're not going to fix anything, and we'll stop doing 3 of them as just, like robots just doing them. The thing about it is epidurals are relatively safe, but they don't do anything. They just give you some temporary relief. So it's not really a treatment. It's not much better than medicine that you take, like pills, and they do have systemic effects. They do raise your blood pressure and raise your sugar, so it's not like they just work on the spine. They actually affect your whole body, and that's not good. I'm sure you'll feel better for a little while, but it's not necessarily healthy for you. It certainly isn't healthy for you. I don't know if that answers your question. I hope it does, but there'll be a world someday where epidurals will be held only for people who can't go have surgery right away to fix their problem. And the reason for that is this. What does an epidural help? An epidural helps inflammation. I don't know how much most of you know, but an epidural is an injection of a steroid into your spine, what's called the epidural space, which is just outside the nerves, just behind the disc, right where the herniations are. And that medicine is the most powerful anti-inflammatory medicine man has. We call it steroids. Okay, you've all heard of anti-inflammatories like over-the-counters, Motrin, ibuprofen, naproxen, Aleve. Those are all over-the-counter anti-inflammatories. Steroids are far more powerful than the over-the-counter anti-inflammatories, and they're more dangerous. Like just the steroid itself is more dangerous. They cause all kinds of problems. Like I said, blood pressure increase, even psychological issues like agitation, anger, frustration. A lot of people say they make them eat more. So, what do you call that? Hyperphagia? Hyperphagia. Phagia is to eat. So hyperphagia is doing a lot of eating. That's why you get those people online on YouTube and they're porking out. And there's like 1 million views or 10 million views of watching them eat. And they've got those moon faces because probably they're on steroids so they could eat more. So you can enjoy their video more. I honestly, it's so funny because I sit here and I publish these videos saving the world from back pain and I get like 200 views. And then you get some people just porking out on whatever, McDonald's, and they've got 12 million views and they're making $1 million a month. And here we are struggling to make ends meet. It's just so silly, you know? All right, we'll take the next question.
The next one comes from Caesarin on YouTube.
Scissorin?
Scissorin? Yeah,
No way.
I believe so.
Is that like scissorin as in the band?
I don't want to jump to conclusions, but I don't see anything reminiscing with the band, but
Sure.
that's their name on YouTube, and they said, I got a T7, T8 herniation that radiates to my right side of the body. I feel miserable every day. I had 2 injections already that don't help.
All right. We can fix you T7-8 thoracic herniation, no problem. We do it all the time. You need this surgery, the Deuk laser disc repair. That was the patient from Brazil, by the way, that we had on Thursday. He had, I think he was what was he, a 7-8 or 8-9? Yeah, maybe T8-9. You can go back and watch the video if you want. Go to our YouTube channel, and you can watch it. It was done Thursday of last week. So it should still be there for you to watch if you'd like. That said, he had a T7-8 or 8-9, and he went home 100% pain-free. Like literally woke up and the pain was gone. He was so happy with his results. We could do the same for you, but it will require this particular surgery right here. This is the way to do it. You don't have to live with the pain anymore. Come get it fixed.
They asked, how can I get in contact, please?
Yeah, so the contact's easy. Go ahead and put the link. It's a free MRI review that we do. You don't even have to pay for it. And I'll meet you on Zoom. And we can do this over Zoom. I don't know where you live, but it really doesn't matter. As long as you've got some good Wi-Fi, we can do a free, what we call a free telemed. It's really just a consultation on Zoom that Deuk Spine offers people like you suffering, wanting answers, and we'll give you the answers. We'll give you the answers, no charge. So you may not come get the surgery, but it doesn't matter. You know, we want to help people like you get answers, and at least you know what's going on and you know that it can be fixed and how we would fix it. So someday I hope we can fix everybody's pain. Every single back pain in the world we want to cure. That's my goal. Nobody should have to live a life with chronic pain in their spine. Okay? Nobody should ever have to live that. It's a horrible existence. I see it in my patients all the time. These are all herniations, by the way. And the sad thing is that a lot of people don't know about us, so they don't find us until they've been suffering for 20, 30 years, you know, with pain. And of course, it's never too late to get rid of your pain. We have patients who are 80, 90 years old that come and get the surgery done because they don't want to live in pain anymore, and I don't blame them. And the sad thing is that other doctors just can't fix them. They don't care to fix them. They don't want to fix them. It's sad, you know? I've gone to the neurosurgeons and I've explained to them, we can fix all these people. I just need you guys to start doing this treatment. And they don't want to. They think there's no way you can fix pain. They honestly believe, and they don't watch enough of my videos obviously, but they honestly believe chronic pain is unfixable. It's sad. Sad that people are suffering needlessly because their doctors are honestly just failing them by failing to recognize the sources of pain and how to fix them. All right, big tear in the annulus here. I've been working on it with the laser. You guys see the laser at 12 o'clock. And that's the spinal cord, by the way, right there. And this is all just shoved into the spinal cord, all this mess. Bunch of herniations, a bunch of stuff. I'm going to pull back just a little bit because I'm having a hard time getting it all. There's so much herniation at 3-4. All of this. Scar tissue and herniation. Needs to go. All right, questions?
Next question comes from Neil, once more, on Facebook.
Sure.
And they ask, how about burning of the nerve? That's all they wrote.
Yeah. needle burning of the nerve, we call it a rhizotomy. We do those here. As a matter of fact, I tell people all the time, the most common cause of neck pain is a herniated disc. The second most common cause is the facet joints. And a lot of people have facet joint pain, and it needs treatment, and we do the rhizotomies here. Except we do it different. We do it called the Deuk plasma rhizotomy. The difference is our treatment lasts forever. Other rhizotomies called radiofrequency ablation or RFA, they don't last. Patients keep coming back. They need more and more and more. And they never get permanent relief. But with the Deuk plasma rhizotomy, we give permanent relief to the facets. We've been doing it for a year now. And we just kind of took a step back and said, why are RFAs not working? And we realized they're not working, why they're not working. And then the worst thing is I realized not just why they're not working permanently, but I realized that people probably know that. The doctors know that. The companies that make the RFA probes and generators know, everyone knows that RFAs won't last forever. They last like 3 to 6 months. And then patients come back for more treatment. Everyone knows that. Even I knew it, but I didn't know that could be fixed. I didn't know there was a solution. That's because I don't normally treat facet joints. I would treat them with a fusion. Like patients who kept getting facet pain, they would come to me from my team and they would say, I'm done getting these RFAs, I need permanent relief, and I would do a fusion. And of course, when you fuse a painful facet, you're going to get rid of that pain. 5 minutes? Okay? So, yes, I was able to fuse them and get rid of facet pain because I immobilized those painful joints. But then I started thinking about it, and I thought, my God, that's so invasive, doing a fusion for that. Maybe there's a better way. Maybe there's a way to make the RFA permanent. And that's when I realized, holy God, there is. There is a way to make an RFA permanent, but it's not an RFA. I guess there's a way to make a rhizotomy permanent, but it's not an RFA. So the technology that I'm talking about at Deuk Spine, we're going to be patenting it. It's already submitted for patent, hopefully. And the thing you need to know is it's permanent. It lasts for a lifetime. So you come and get it done, and you go, and you're done. We've done how many, Luis? 100 patients? More? More than 100. We do them all the time. We do them for the cervical, we do them for the thoracic, we do them for the lumbar, and we do them for the SI joint now, the sacroiliac joint. Oh, by the way, all those SI fusions happening out there, totally unnecessary. Nobody needs another SI fusion. We're done with SI fusions. You don't need it. So if you've been recommended for an SI joint fusion, forget about it. My God, they're going to go away completely. There's only one time an SI joint fusion is going to be needed, and that's if you have an anterior pain from the front of the joint, which we can't rhizotomize. Okay, just about done. I'm still getting some more fragments floating out, so I'm not quite done yet. I'm going to keep working on this, but probably 5 minutes or less. If you have questions, type them up. I will answer them for you. I'll answer them face to face. That's a bone spur, by the way, right there. You see that? That's what a bone spur looks like. I am melting that sucker good. Goodbye, bone spur. Still a little herniation there. Getting rid of that too in the foramen. That's on the right side at C3-4. So far, this patient's surgery is going really well. We had a nice prayer session before surgery. Everybody prayed together, and it looks like God is listening. By the way, those fibers down there you're seeing, those white things, that's not the spinal cord. That's called the posterior longitudinal ligament. That's normal. It should always be there. And you can see it was torn over here through trauma. And that's what I was cleaning up earlier. getting rid of the herniation that's stuck in there. Okay. Questions? Just type them up. I'll come answer them for you. I'm just about done. And I'm going to show you the incision. That's the spinal cord right there, that kind of pinkish thing. And I've gotten rid of all the herniation that was there. Okay? And now we're pretty much done. Let me just take one more look. Yeah, it looks really good. See the big hole there? Let me just get a little bit of that right there, and then we're done. All right. That's pretty much it right there. Looks good. Remember, as a surgeon, you never want to gild that lily. You want to do what you need to do to get rid of the symptoms and then move on. You're never going to get 100%. All right? And I'm not going to fall victim to the gilding of the lily. I'm always talking about how you shouldn't gild a lily. Just want to make sure we clean everything out. Looking good. Let me just turn this. All right, I'll come answer your questions. But man, things are looking good. I don't see any more inflammation or herniation. All right, great case. 4 levels. We don't do a lot of 4 levels. And all right, who let the vampire in the operating room? You can see the pieces of herniation right there, right guys? Did you see that, Henry?
Yes, we did.
So the herniations literally float out of this tube, and I'm going to take this tube out. And then I'll show you both incisions. Wow, what a difference, huh, folks? Versus open surgery. Here's a piece of herniation I was talking about. You guys see that? They're kind of everywhere. They just float out. We don't collect them all. All right, let's take a look. See what I mean? Somebody let the vampire in the operating room. Anybody see Nicolas Cage hanging around? Okay. All right, so let's take a look right there. 2 little puncture marks, and Luis will hold a little pressure for a few minutes. And then we're going to close that up with a little bandage, a little steri-strip, and that's it. All right, type your questions up, and I'll be right there to answer them for you face to face. 4-level cervical Deuk laser disc repair. Great job, everyone. Great job. Good morning, I'm Dr. Deuk. It's December 9, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he is suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes, sir. Yes, Doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, Doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no grip. And today, it's all back. I just, you know, it's just a game changer. His procedures, because I've had fusions in the past, like 15 years ago, and those fusions, you don't want to do those because they just give you adjacent disc disease, and I have that problem right now in my back, and Dr. Deuk is going to fix it next week, so I'm very looking forward to doing that.
We'll be seeing him again next week after his back is fixed, but you broke it up into 2 procedures, and we get people all the time asking us, oh, can I come there and get my neck and my back fixed? Yes, you can. We'll probably do it on separate days. So you got 3 discs repaired yesterday. You can
Yes, sir.
actually see right here in this video footage how small the incision is, tiny. And I was in there endoscopically using a laser to clean out the tear and remove the small herniations. And now here we sent you home an hour after your surgery, and here you are back today. And how much of that pain did we get rid of?
All of it, Doc.
100%.
100%. And doctor did, they did surgery on 3 different levels and through a really small hole.
4 millimeters.
Yes,
4
Doc.
millimeters. Incredible.
And there's no stitches. It's just a Band-Aid.
Yeah.
You know, that's crazy. You know, if you have a fusion for three-level fusion, I don't know how long that would be, but it's
it's
terrible.
about that long
Yeah.
for a 3-level fusion. And then of course you'll have swallowing trouble for months,
not
and
good.
then you'll have pain, and you'll be on narcotics. Are you on any opioids or narcotics?
No, Doc. Last night I went home and to the hotel, and I just took a Tylenol PM, and that's all the medication I've taken since the surgery.
Yeah. So with the Deuk laser disc repair, you don't have to worry about getting addicted to painkillers, because there are no painkillers. Literally a Tylenol, and that's it, because it's so minimally invasive. Far better than ACDF, far better than any other cervical type of surgery. Well, is there anything else you want to tell your fans out there before we wrap this up?
Yeah, I just want to let my parents know, and my 10 younger brothers and sisters, if you're watching this, if you have back issues, you need to come see Dr. Deuk, because he is one of the only people in the world that can do this procedure, and it is a game changer, and it's well worth it. At least give him a review. He'll do a free MRI review for you. It's just do your research. Go to his DeukSpine.com, look at his website, and just do your research and give yourself a chance to do the right thing.
Well, thank you. And yes, now I'm the only one, but someday there will be another one
You hope.
who will be doing these surgeries, and probably better than me.
Okay, thanks, Doc. Appreciate
Thank
your
you,
help.
sir.
Yeah.
We'll see you soon.
Yeah.
Good morning, I'm Dr. Deuk Majan, CEO and founder of the Deuk Spine Institute, here with one of my patients who traveled from Mississippi.
Yes, sir. Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Deuk Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg, and went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Deuk here.
And what do we do for you?
You guys did a C3, I think 3, 4, 4, 5, 5, 6 at the Deuk laser disc repair surgery.
And before surgery, you had neck pain?
Correct.
For how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder, down your right arm?
Correct, just getting progressively worse. And that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Deuk laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No, sir, zero pain.
Gone?
Gone, completely gone.
Cured?
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. It's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a, what do they call a spinal deformity doctor. And they possibly looked at like doing rods and pins and all that kind of good, the fusion and everything. So it just kind of...
Why didn't you want to do the fusion option?
Long time recovery time and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working in my house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding, and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck. Your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C3-4, C4-5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Deuk Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday, and I feel much better flying on the plane than I did earlier. Just thinking, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4mm incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm, so that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to the Deuk Institute of laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you
Safe
so much. I
travels
appreciate it.
to
Thank
you
you
and
so
Dad.
much.
And if
We
you-
will.
Yeah.
Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So
Okay.
worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, safe travels for you then.
Thank you so much. I sure appreciate it.
My pleasure. It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March. And I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did a
he
lot
did
of
a
Googling.
lot of research, and we found Dr. Deuk to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve, and we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees
nice.
and then they woke up to about 11 degrees.
So the cold front came in. We get those from time to time, and it gets cold around 60 degrees. But most of the time, it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Deuk will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So, go for it.
I said that it was so important that I said I'd pay for it. Because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you pass away.
All right, folks, we'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice shake. Well, I hope you enjoyed hearing from one of our patients who had the Deuk laser disc repair. This is a state-of-the-art type of surgery done on the spine for herniated discs, bulging disc, ruptured disc, protruded disc. A lot of people think I've got a disc bulge, therefore I don't need treatment. The doctors told me I don't need treatment, just therapy or pills or shots. But disc bulges are surgical problems. They only go away with surgery. The symptoms only go away with surgery. And you may experience periods of time where the pain gets better and then it gets worse again with activities, but that's typical for a herniated disc. And the reason why activities stir up pain is because the disc is a joint. It's a joint that actually moves. So if you think about it, the more active you are with your body, the more you're bending and twisting, you're going to be putting pressure on the disc, and that pressure on the disc is what pushes out those little pieces of herniation that you just saw me take out. I counted probably over 50 herniated discs between those four discs. There were 50 pieces of herniation, and maybe more, probably closer to 80 if you count the real small ones that were around 1 millimeter or 2. Every time you get active, you start doing things, you're putting pressure on those discs, you're pushing out more herniation because the tear is still there. And until the tear seals closed, which it never will do until you have the Deuk laser disc repair, you're going to keep herniating pieces out, and you're going to get this cycle of worsening and bettering and worsening and bettering until eventually it's just pain all the time, and you got to do something to deal with it. And by then it's crisis mode. Thank you. And most people are just willing to lay under the knife and get a fusion done, and then they've just started down the rabbit hole of hell, because fusions cause more fusions and more pain management and more problems. Artificial discs are no better. They're just as bad, if not worse, than fusion. So what does that leave you with, folks? It leaves you with the best choice available in the world, which is what you just watched: endoscopic Deuk laser disc repair, available here at Deuk Spine in Orlando. Our next patient is from Hawaii, and we're not going to be broadcasting. He has requested us not to broadcast. He's a private man and wants basically no record of him having surgery here. Not in a bad way, but he just doesn't want any recording or broadcasting. So we'll respect his opinion. It's not often we have patients that we don't broadcast, but the next patient is traveled all the way from Hawaii, and he's going to be having 2 discs in his neck repaired, as well as the Deuk plasma rhizotomy in the back of his neck. But we will not be watching that. So we're going to take a break for a few hours. In the meantime, I'll answer some questions from our audience.
Copy that. This first question, let me find it. Yep, right here. First question comes from Chris on YouTube.
Hi, Chris. Welcome to our broadcast.
They ask, doesn't moving the endoscope damage or disrupt the disc? Like if you have the scope in the disc and move it from one side of the disc to the other, doesn't that move or disrupt the contents of the nucleus?
Hey, great question, Brad. You are correct to think about that and worry about that. So let's pretend my arm is the endoscope and I'm inside the back of the disc. I go from the left to the right, from the left to the right, and I remove the herniation along the entire back of the disc. And the question is, doesn't the endoscope like damage the disc as it's windshield wipering through? The answer is no. And the reason is simple. The disc is already damaged. So we're actually moving through a damaged zone of the disc. And we're not creating any damage, we're just going through a damaged area. Imagine if I had a tank and I brought it to your house. Would I do any damage on your driveway or your house? The obvious answer is yes, I would. The tank is going to tear things up. But what if I took that same tank and I went to a city in the Ukraine that's been bombed out by Russia, and I brought that tank through that city? Would you notice any damage? Nope. Why? Because the damage is already there. The tank is not going to make more damage just rolling through town. There's the difference right there. So if I took a normal disc, perfectly normal, and I stuck the tube in and I windshield wiper, absolutely, I think it'll tear stuff up. But with a disc that's already damaged, it doesn't do anything. And more importantly, my friend, I'll just make a comment to everybody that's thinking about all these things. You're right to have these thoughts, suspicions, concerns. It's great. But in the end, you got to look at the results, okay? And you got to say to yourself, how are these patients actually doing with the surgery? And the answer is, we're curing their pain completely, permanently, for the rest of their life from those discs that we're treating. So it can't be that bad, right? I mean, tell me what else in life cures neck and back pain from a herniated disc? I mean, a fusion might, but then there's a huge collateral damage. So the procedure works, the proof's in the pudding, as I always say. Nothing to be concerned about. There is no long-term sequela from the tube being in the disc, but it's a great thought.
Next question comes from Canes25 on YouTube. This is
How you doing? Huh?
This is, doesn't have to relate with spine surgery. He was curious, seen any good movies lately?
Seen any good movies lately? Yeah. Thank you. What did I see? I saw Dungeons and Dragons with Chris Pine, which I thought was pretty good. It's entertaining. And then I saw the Dracula one I told you about with Nicolas Cage. Renfield is a little bit disappointing. There was definitely some good stuff in there, but overall the plot was a little slow. What else have I seen? I'm looking forward to seeing that movie with that Swedish guy that, you know, he came across the Nazis out in the desert or something. Sanska or Skuza or something like that. Sisu.
Yeah.
So I pre-bought that on Apple, and I'm waiting for it to be available so I can watch it. But that looks really good. And then
I'm dying to see that. It looks so good.
It looks really good. And then I started watching the Lord of the Rings, J.R. Tolkien's The Hobbit, The Lord of the Rings with my son.
Never gets old.
And that's really good. So we just started watching that again. I watch that every couple of years. Last time I watched it was with Mom. We did a movie-thon, my mom and I. I think she was recovering from something, and we hung out together. But how about you? Any good movies you recommend? Love to hear from you. Type them up and I'll check them out.
Your next question comes from Jonah on YouTube.
Hi, Jonah on YouTube. Welcome.
Jonah asks, this procedure doesn't decrease the height of the disc?
This procedure does not decrease the height of the disc is the question. The answer is no. Remember, folks, we're not operating on a normal disc. That's very important for you to understand. The discs are already damaged. They're already desiccated, collapsed, herniated, bulging, spondylitic. These are not normal discs. And so when we're going through the disc to get to the back, the disc is already collapsed many times. I mean, I don't think I've ever operated on a normal disc, so every disc we've operated on, they've always lost some of the disc height, they're dried out, etc. We're not making them worse, we're making them better. Just so you all understand, spinal instability is defined as pain, excessive pain, or neurological deficit that occurs with normal physiological loads, which means normal activities, right? So just everyday activities. You got pain in your back or neck, you got nerve symptoms down your arms or legs like numbness, tingling, weakness. That's the definition of instability. So we are eliminating the pain, we are eliminating the nerve symptoms with this surgery. Therefore, we are eliminating instability. That's the truth of the procedure. It's a stabilizing surgery, even though we're not doing metal or fusion or artificial disc. So it's proof in point that you can create stability in the spine without doing open surgery by just repairing the annular tear, removing the herniations.
Next one comes from Lisa. Yeah, Lisa.
Hi, Lisa.
YouTube.
On YouTube, welcome to our live stream.
They asked, I believe this is seeking for advice. I had a herniated disc on my C4-5 disc pressing on spinal cord. My doctor fused it, and one of the screws is now pressing up against the thecal sac. I have many other cervical problems. I really need you. I'm in so much pain. My eyes are getting worse, and my tinnitus is so loud. Cat's fisculations.
I see. Well, first of all, I'm very sorry you had a bad experience with the fusion done. I'm happy to help you if I can. Obviously, I will. Feel free to do our free MRI review. Submit your latest MRI and x-rays. I would encourage your x-rays as well. You may actually have a CAT scan. Most surgeons of the spine would order a CAT scan if they have a screw that's questionable. But basically, for our viewers, she had a fusion done. This is a 2-level plate. She had a single level. That would be a single level plate right there. As a matter of fact, that is C4-5. And they probably put a cage in. You could see the cage. And then, of course, the screws and the plate. So she's saying one of the screws, I think, is in too far, and it's pushing on her thecal sac, which is the covering around the spinal cord. And I assume that your tinnitus, which is the ringing in the ears, started after the surgery, which is unfortunate, and certainly could be due to a spinal fluid leak if the screw punctured the dura and caused a spinal fluid leak. It's an unfortunate situation, but it's, again, it highlights why I tell everybody avoid fusion, avoid fusion, avoid fusion. Even if you get the best fusion in the world, or even avoid artificial discs, if you get the best invasive surgery done in the world, the surgeon is still destroying your normal spine. They're destroying the muscles, the ligaments, the tendons, the joints to get their job done, whatever it is they're doing. Laminectomy, foraminotomy, they're removing bones and ligaments and joints. That's only going to weaken your spine, make it worse. So I'm sorry you had a bad experience with the fusion. Folks, please try to avoid fusion and metal. Do the endoscopic Deuk laser disc repair. I look forward to trying to help you. Feel free to upload your MRI on our website, mri.deukspine.com, and I'll be happy to meet with you.
Next question comes from Oz on YouTube.
Hi Oz, welcome.
And they ask, do radiologists read MRIs as good surgeons?
So the question is, does a radiologist read an MRI as well as a surgeon? That's a great question, Oz. In general, surgeons are the ones that are ultimately responsible for fixing a patient's problem. Let's just say spine problem. And we, as spine surgeons who hold that responsibility to the patient to do what's best for the patient, we have an obligation to be able to understand the information that's available on the patient's condition, including MRI scans and EMGs and x-rays. And we have to hold ourselves accountable to interpreting those studies properly and making the right decision for the patient. So it's standard training for neurosurgeons today that they take radiology courses as part of our training. I had to spend, for example, 3 months on neuroradiology during my neurosurgery residency, where I learned how to read MRIs of the spine and brain and other studies like CAT scans and angiograms, etc. So it's part of our training. Are surgeons better than radiologists? I'll be honest, there are some radiologists that are really, really good, but that's only like 1%, maybe 2%. And there are some surgeons that are really, really bad at reading studies, and that's like 50%. So what's more important is you get a doctor who really knows what the heck they're doing, and they're able to interpret the MRI properly and find the abnormality. When I do MRI reviews with people on Zoom every week, I actually pull up the MRI, go through the slices and the sequences with them, and I show them where all the problems are. And to be honest with you, I only use for spines basically two sequences. It's called the T2. T is in a capital T, number 2, T2, sagittal, T2 sagittal, and the T2 axial views. And I put them side by side, and I can literally slice through every section of the spine, and I can see where the line's going through on the axial view, and I pretty much make all my decisions based on T2 sagittals. Now that's completely different than what I was taught as a resident in neurosurgery on spine. I was taught to look at T1 axials, and that's pretty much it. But the truth is, T1 axials don't give you enough information about where the real problems are. So I learned over the years that the T2 sagittal was the very best test. Great question.
Next one comes from Neil on YouTube, and they ask, is PRP injection, I believe it's called, guaranteed to regenerate degenerative discs? What is the best solution you have to degenerative disc?
Hey Neil, so first of all, PRP, it's a great question. PRP is platelet-rich plasma. What we do is we suck the blood out of somebody, we spin it down, we get the plasma, which is the stuff at the top, the clear stuff at the top, the red blood cells are at the bottom. We just take the plasma, it's full of platelets, we suck it up in a syringe, and then we inject it into your body. And the kind of places we inject it are joints, typically, but PRP in the disc doesn't work. It doesn't work. We tried it. We do PRP here, we do stem cells here. It doesn't work. Now, we as a company, we cannot take people's money. We cannot do an invasive treatment knowing it won't work. It's unethical. It's immoral. It's against our standards at Deuk Spine Institute. That doesn't mean other doctors won't do it. And there's 2 reasons why they do it. Number 1, they want the money. And number 2, they truly believe, many of these doctors, that you are unfixable with your disc problem. Therefore, since it can't be fixed, might as well just throw everything at it that you can. Well, we don't agree with that, because we know your disc can be fixed. And we're not just going to throw everything at it and take your money. We want to take your money and give you a result that you can live with the rest of your life and be proud of and be happy with, and you can go back to normal activities. It's just a very big difference in, number 1, our understanding of disease affecting the spine and discs, but also number 2, our values and what's important. For us, what's important is that we fix the patient's problem. So PRP will not fix your disc. It will not stop the degeneration. It will just make you $2,000 poorer and still in search of a solution. What is the solution for a degenerative disc? You just watched it, my friend. It's Deuk laser disc repair. The surgery we just performed is the solution for your problem.
Next question comes from Oz, once more on YouTube. They asked, if you needed surgery, who would you choose?
Oz. Did you ask me that already a couple of weeks ago? Somebody did.
I believe so, yeah.
If I was going to have surgery, I would choose my son, Arias Deuk-Majan, to do my surgery, because I trust him. The kid is very smart. And I believe someday he's going to be an even better neurosurgeon than me. If I had to have surgery today, I'd probably have Dr. Patel do it, my partner. I trust him. That's about it.
The next question comes from Lisa on YouTube. They ask, does anyone do what you do in Australia?
Does anyone do what we do in Australia? Lisa, unfortunately, they do not. Like the rest of the world, they're stuck in the, as you know, in the fusion mode. Lisa, there's too much money and too many people profiting from fusions for them to just go away on their own. They're going to be around for a while because the hospitals like them, the surgeons like them, and the companies that make the screws and rods love fusions and artificial disc. Anytime metal's going into your spine, they're making money, a lot of it. Same thing in the United States, same thing in Canada, same thing in South America. It doesn't matter where in the world you go, it's true. So if you really want to know where is progress with minimally invasive spine surgery being made, it's in the poor countries, the ones that cannot afford the metal. If you look at India, for example, there's more and more Indian spine surgeons doing endoscopic surgery. Bravo, kudos to them. And a large part of it is maybe cultural, but also they want to do better and they don't want to pay for metal. Okay, so they're moving away from it. China, same thing. Hate to say it, China is actually, there's a lot of good Chinese surgery starting to happen over in China where they're doing endoscopic surgery, and they're certainly going to be leading the world. Well, they're never going to be better than Deuk Spine Institute for sure. Nobody will. But there'll be more volume than us. They'll be treating more patients. But from a technique standpoint and from a quality of outcome, no one will touch Deuk Spine. What we do, nobody else can do. But basically, Australia does not have any endoscopic surgeon that I would ever go to or trust. So.
Next question comes from...
Let me just say one thing. It's important you all understand. It's not the fact we're doing endoscopic surgery that's so good, but it's how we do the surgery that's so good. It's not just the fact I have an endoscope, tubes, all this stuff, because you can hurt people with an endoscope if you don't know what you're doing. So it's not what you have, it's how you use it, right? That's what really matters. And the technique that we have here is the best in the world. It's virtually flawless. And that's because over the last 20 years I've evolved it, and I've incorporated all my experience as a spine neurosurgeon doing open surgery like fusions and laminectomies. I've thought about the anatomy, I understand it really well, and I've modified the endoscopic technique to be able to utilize my knowledge and experience to make it very good. And that's why we have great results.
And then, last but not least, it comes from Caesarin once more on YouTube. Caesar?
Caesar.
Yes, Caesar. On YouTube, and they asked, does anyone do what you do in New York? They want to put metal in my T7, T8.
Yeah, Caesar, I'm sorry. Nobody in New York does what we do. Nobody in the other 50 states does what we do. I should say 49 states. You can only find this surgery here at Deuk Spine in Orlando. We have a lot of New York patients, New Jersey patients, a lot of patients from Northeast United States, Massachusetts. They all come here. They fly here for 3 days and they fly home after 3 days. This patient you just saw done is from Michigan. The next patient is from Hawaii. I think we have another patient from California today. So people travel here. It's like if you want to go to Paris, France, you want to see the Eiffel Tower, you have to travel. You know, the Eiffel Tower is not going to come to you. And anybody that tells you they have the Eiffel Tower in New York, go the other way.
And that's it.
All right, I hope you enjoyed the broadcast and learned a lot. This was a great surgery. It went very well. and I think this patient's going to go home in about 10 minutes. So our next surgery we will not be broadcasting because the patient doesn't want it broadcasted. So we are going to be coming back for our third surgery with a lady who is having a Deuk laser disc repair lumbar L5S1. All right, go take a break, go watch a movie, enjoy yourself.